Chapter 17, Pediatric Emergencies. For pediatric patients, the younglings, they have sudden illnesses and medical emergencies that are only common to the children and the infants. And so when we are talking about this, we need to know that these won't apply to adults. And not only that, because there's less reserves for the children and the infants in their body, in their physiology, they're going to rapidly decline. So we have to be very uh, aggressive in our treatment plan and yet gentle for the patient. There are anatomical differences, not that there's different structures, but they're different sizes and proportions. And very, very important to support the respiratory in an infant. So let's get to it. Uh, the most stressful situation you could ever face as an EMR or as a rescue worker at all is dealing with a PEDS patient. Um, One of the main things to do when you're dispatched to, or even when you show up to a PEDS patient, is to remain calm. Force a calmness over you, because your anxiety level will ramp up the child's anxiety level. It's going to ramp up the parent's anxiety level, which in turn is going to ramp up the child's anxiety level. So we have to be able to go, okay, I need to go game face right now. I can freak out on the inside, but on the outside, I gotta be calm, like a duck on a pond, right? I gotta be calm on the top. My feet can be churning like a million miles an hour under the water, but it's got to appear effortless and flawless. Because, like I just said, parents can either be allies or problems. If they perceive that you are all over the map, they're going to be very concerned with their child, as they should be, and they could cause a greater anxiety that causes the child to be anxious. You're going to talk with both the parents and the child as much as possible. You don't want to ignore mom and dad because you're talking to the patient, and you don't want to ignore the patient because you're talking to mom and dad. Uh, you want to develop a rapport with the child, and that might mean you pull out one of the little toys that you have in a Ziploc baggie in the back of the truck. Make sure that you're down to their eye level and that you're asking simple questions about their problems or their pains. Right? You see here, you've got mom there, and you've got the child in the background. You do have the teddy bear available, and these are givable away. You give them to the child and let them keep it as a reminder that someone was there that cared for them. Right? Be honest, don't lie, but on the other side of it, you don't need to use big scary words either. So as we look at the differences between an adult and a child, the child's tongue is bigger proportionally speaking. The airway's not fully developed yet. Their head is bigger proportionally. And because of that, the airway is more easily occluded. And so we got to be mindful of opening the airway and keeping the airway open as we're talking about uh, airway maintenance. It's also more flexible. So if you overextend it, if you do the head tilt chin lift, you could actually over open the airway, which would cause the airway to be closed off as well. So we have to be very, very careful, especially in the first 6 months of their lives, because they're super floppy, they're super funnel shaped, right? And infants only breathe through their noses. They're obligatory nose breathers. Why is that? Well, typically speaking, they have something in their mouth all the time. They're always hungry. So there's either a breast in there, or a bottle in there, or a pacifier in there. Something's in their mouth, and so they're breathing through their nose. So if they've got a lot of snot and grossness going on there, it's going to be hard for them to breathe. All right. So this goes with if the child is having a hard time breathing, um, they're able to respond quicker. Their body is, but they're unable to compensate as long as an adult will. So they're going to look okay maybe to start with, and then they're going to degrade quickly, whereas the adult slowly degrades over time. We're going to use a simple 5-step method um, as we do for any other patient assessment, right? We're going to perform a scene size up. We're going to do a primary assessment. And then we're going to complete a secondary assessment, but this time, instead of going head to toe, we're going to complete the assessment, but instead of doing it from a head to toe, we're going to do a toe to head. We're going to start at their feet and work their way back up. So we're still doing a head to toe, it's just in reverse, right? Sample history, we're probably not going to get that from the kid. That's where parents come into play there. And then if we need to do a reassessment, then we'll do a reassessment. This is the standard for evaluating young people because the small patients don't really appreciate unknown people handling them. So we're going to use the PAT assessment, the Pediatric Assessment Triangle. Okay, it helps us to form the general impression, and we can assess the child without actually getting up in the grill, right? And so the PAT assessment, Pediatric Assessment Triangle, has three portions of it. We have the appearance, what do they look like, right? We're going to break each one of these down here in a minute. Work of breathing, are they distressing or are they not? What is their circulation? Well, we're going to look at the color. So the appearances, are they moving around, um, that kind of thing. And circulation in the skin will be more of the color of their skin. So let's break them down. Appearance. How well is the heart, lung, and the central nervous system working? Are they lethargic? Are they moving around? Are they making eye contact? Are they staring off into space? Are they agitated or restless? Or do they appear to be, interested in the toys or whatever else? What is their appearance? Now, there's a nifty little charts here you can look at, and some of this is just a comparison of what is normal and what is are healthy, I should say, and unhealthy, because normal is a relative term, right? Let's talk about the work to breathe a little bit. Are we hearing them with abnormal sounds, slurping, gurgling, grunting, snoring, crowing, wheezing? Those weird sounds are going to give me an indication of where I might have to go and assist with, right? We don't want to see that. We don't want to see retractions, muscles between the ribs. If they're really battling to breathe, are we seeing those retractions? Are we seeing seesaw breathing? Those kind of things, okay? And so with all of that, that is our assessment for how are they breathing. What does that look like, okay? So we had the appearance, we've got the work to breathe, and then we have what does the skin look like, right? What does the circulation look like? Do we see, are they pale? Are they mottled, which means their heart's not working well enough? Are they cyanotic, which means you're not getting enough oxygen into the system? So what is the skin look like? What is that going on? Okay. So just like anybody else, we're going to do an assessment here. We're going to get the number of respirations, right? How well are they working to breathe? Are they making any noises? Now this is saying get it for 30 seconds, then multiply it by 2. We're taking a vital sign, right? We don't have to touch the kid to do a vital sign. You can do the 15 by 4 method as well. 15 seconds and then multiply by 4. Either way, as long as you get a respiratory rate on the child, infant. And then we need to, are they taking care of themselves, right? Or are they in a weird position? These are the things, as we're looking for the respirations for the work to breathe, that we really need to make special note of. As we continue on with the pulse rate for the infant, we're going to get the pulse rate in the brachial. And this looks like a happy baby here. And we're taking a pulse rate in the brachial. The radial is not going to be effective, and we're definitely not going to try to choke the kid out by doing a credit, because little babies don't have necks yet. Here's just a normal, the normal or the average, as it should say, pulse rates and respiration rates. These are nice to haves in there because it'll be depending on what curriculum we look at as to what they're saying is normal, right? I don't expect anybody to remember all these numbers, but I do expect you to know the smaller the person, the faster everything is, right? So that adolescent, that 12 to 18 years old, Those numbers down there are the adult numbers. So the heart rate 60 to 100, respiration is 12 to 20. That's normal average, right? But if you notice, as you go closer to the newborn range, everything gets faster, right? And the adult ranges of breathing and the adult ranges of heart rates are not good for the littles, okay? So there you have it. Those are the kind of the normal ranges. This is in your book. It's table 17.4. You'll find it in your textbook in chapter 17 for your averages there. Now, one of the main things that we have a problem with infants and children is the high body temperature. Uh, they are very susceptible to illness because they haven't been exposed to much yet. They're young, right? In fact, somebody was telling me the other day, one of the younglings in the EMT class, I was kind of getting after them because why are you guys sick all the time? And they're like, well, we're younger. We haven't been exposed to much. And I thought that was a smart aleck response until I actually thought about it, which is a true statement. You've only been around for 16, 17 years. You haven't, you haven't had enough exposure to all the methyl bad crap. And so, maybe this is a normal aspect of your lives. But for temperature, we need to feel the temperature. We're going to touch the child's chest and head because that's where the core heat comes from, right? And even doing that, we'll be able to feel their breathing pattern. We'll be able to actually feel their pulse through their chest wall because they don't have a lot of fat yet. And are they restless? Are they sweating? And this is going to be indication of underlying medical problems. When we talk about respiratory care, especially in the medical emergencies for the children and infants, we are most especially worried about their airway. I mean, the number one cause of cardiac arrest in children and infants is respiratory arrest. Something going wrong with the respiratory, and out goes their cardiovascular, and the rest of the body follows. Right now, typically speaking, with the littles, they're putting stuff in their mouth all the blessed time. They're always putting stuff in there. They also have because they have such a narrow airway already. Any infection like croup or epiglottitis, that's going to cause problems to the airway. Now, we also have SIDS, sudden infant death syndrome, right? That is a very, very sad moment where they pass away in their sleep because of uh, uh, factors of suffocation. They got too many toys or blankets or breathing CO2 or whatever. Um, these children also poison themselves by eating things under the sink if the cleaning materials aren't stored correctly. And of course, the number one cause of death in children and infants is trauma. So the number one cause of cardiac arrest is respiratory arrest, and the number one cause of death is trauma. Right. So these are the things that cause the littles to expire. So as we begin to think about treating for respiratory emergencies here, we're going to do a head tilt chin lift. Now notice that this rescuer is not like really reefing our head back. It's more of in line with her body. Why? Because her body is not proportional to her head yet. And if I was to open her airway even farther, it could pinch it off going backwards because it's so flexible. Notice that the shoulders are kind of coming off the ground, and that's because of that the difference in the proportions. Maybe you want to put a little towel there to help you keep that airway open. If there's a possibility of injury, obviously, just like we do with the adult, we will do the modified jaw thrust maneuver. Right? We're gonna try to push that open, and then uh, we have to remember it for basic life support. There are a little bit of differences there in CPR. 1 and 2 person CPR. With a 1 person across the board, it's 30 to 2, 30 compressions to 2 respirations. But the depth of the compressions is slightly different. We have, you can use 1 hand rather than 2. The placement's still going to be the same, but we must make sure that we're not like pushing as far down in a child as you would as an adult, right? But with 2 rescuer CPR for children and infants, you switch to compression patterns to 15 to 2. Why? because both respiratory and cardiovascular rates are faster for the smaller people. Obviously, we run through our AHA algorithms for basic life support. We check for responsiveness by tapping the infant's foot, uh, but we don't like knuckle down on their sternum. That's just not right. For the infant, we check at the brachial pulse. For the child, we can choose the carotid if there's enough neck there to do so. Uh, and then just uh, we want to give them just enough respiration, breath if we're doing mouth to mask, that just to see the chest rise because our lungs are bigger than theirs. Sectioning, we can suction. That's fine. Again, it is going to go as far in as you can see at the base of the tongue. If you have an OPA or an NPA in place, you can use the same procedures to suction as you would an adult. Um, no more than 5 seconds is the modification here. And we would prefer to use the bulb syringe for an infant rather than the suction unit, just so that we're not disrupting tissue and causing more issues with swelling. We already know how to do airway adjuncts. It's the same as we would for an adult, but we very rarely use nasopharyngeal airways on the children. It's just not something that we do. When we're in full arrest mode, we're typically OPAing in and then moving on. Okay. Now, if they have a mild or partial airway obstruction, uh, and we can see it, well, then we can go and get it. All right. But if the patient is breathing, I'm gonna leave it alone. Does that make sense? So if you can see the obstruction uh, in, in a semi-conscious state and they're not able to pass air, and you can see it, go get it. But if you can see it and they are breathing, just keep them super calm. I think of the child who shoved a Lego up his nose and the airway was blocked. Nothing much I could do for it. So we just had him open his mouth. It was an autistic child and he was listening. But his nasal pharyngeal area was totally closed off and he was having a difficult time breathing. Just keep them calm and let them go to the hospital. That is. And maybe we can go ahead and give them some blow-by oxygen. Um, Oxygen is something that we do. We are trained to use it, so you are to use it. Interestingly enough, not all areas in the country allow for that. However, you are, so do it. Uh, this would be the appropriate size mask to the patient, but we don't want an airtight seal because kids don't like things on their face. So just do some blow-by oxygen through a properly sized non-rebreathing mask. As it progresses worse, if it's getting worse, we need to do something about it. Okay, they can't speak, they can't cough. We're into the choking method, whether it's phlegm that's in there or food or a combination of both. We see here that you can go ahead for the Heimlich maneuver, which is the abdominal thrusts. You hear people call it Heimlich maneuver. You hear people call it the abdominal thrust. But basically, what you're doing is you're doing the same thing you would for an adult. We're going to be pushing up and in an attempt to dislodge and get them to cough that out. If they pass out, then we move on into CPR algorithm with the looking in the mouth to clear the airway. There we go. I mean, we're going to do the same thing in the same way for a child. There is differences for the infant, but we'll get to that in a moment. But for the child, we just need to get things kind of cleared and rolling. Now, if we do wind up in CPR, remember that we're going to do 5 cycles before we lay the AED on them. Remember, the smaller they are, the more fragile they are. It's kind of like the paradoxical to the geriatric, which is the older they are, the more fragile they are. So at the very beginning of life and the very ending of life, it is very fragile times. But if their patient is conscious and crying, I love crying infants. That means their airway's open and they've got a good pulse. But if the infant is not crying, or it appears to be silently crying, then we're going to have to do something about it. We do that by 5 back blows and 5 chest thrusts. They call this back slaps. I don't like the word slap because it's an open hand. My goal is to squish the air out of the infant and push, use their little lungs as a billows to shoot whatever's in there out of the way. Face down, the head is always below the butt, using gravity to help you. It might be helpful if you're sitting down, if you've got a little bit porker like this little one here. There's a little smushy munchum. But if you've got enough strength in your forearms, you want the baby directly on your forearm, right? You can use your leg for support. Then when you flip the kid over and do the chest thrusts, again, the head is going to be below the butt, and we're going to do 5 chest thrusts in the same place that you would do CPR, compressions. Okay? 5 back blows, 5 chest thrusts. 5 back blows, 5 chest thrusts. And then we're going to continue that until the patient starts crying or they go unconscious. If they go unconscious, then we go into CPR mode again. Okay? If the child or the infant ever goes unresponsive as a result of choking, you need to make sure that the rest of the EMS systems know and are coming in hotter. Okay? I'm sure with the dispatch information, everybody's going to be ramped up anyway, but you're gonna update everybody else so that they're prepared for next steps. CPR gets underway, and we make sure that we're doing the best we can until we get transport units on scene. Now, if small objects don't occlude the airway, normally they go through the child and they pass out. They poop them out, right? So, like a dime or a nickel or a quarter, and one of the jokes I saw in Grumpier Old Men was, yeah, kids are always eating quarters. It's when they crap out 2 dimes and a nickel where you have to worry about it. I thought that was funny, back then, but the reality of it is that'll pass through. Now the problem on the other side of it is if it's sharp or straight objects that might get bound up inside of their intestines. In either case, we're going to want a range for transport. We want them to go get looked at and make sure that everything is going well there. But anything that's swallowed needs to go in and be evaluated. Now, as we begin to look at a child or infant and evaluate them for respiratory distress, anything more than 60 breaths in a minute for an infant, now they're struggling. It's above normal, and we don't want that to happen. Any breathing rate above 30 to 40 for a child, again, is outside the realm of normal, and we want to be very cognizant of that so that we can be paying attention. What can I do to help fix this? Because I don't want Junior to be in distress, right? We see nasal flaring and retractions. Again, we talked about that earlier. Those are signs in our PAT assessment, right? Don't forget our pediatric assessment triangle. That we're going to ooh, that's something that we're going to have to fix if we can. What do they look like? What's their skin look like? Are they acting normal or are they acting altered? Well, we don't know that, so we have to ask the parent, right? Are they combative or restless? And is it normal for them to be combative or restless? Maybe this is the way they are normally. What we're looking for abnormalities. When we look for those abnormalities and we find them, then we can begin to start figuring out how we can fix those things and make it better. We gotta drill down to why, and make sure if you can to make the kid as most comfortable as possible. Now remember, comfortable does not equal unsafe. So if we're going to help them be transported in an ambulance, if we're going to arrange for that transport, they still need a car seat. They still need to be restrained properly, not sitting on parents' lap. In any situation, we're trying to keep the child calm. We want to keep, if they can hold hands, if they can be in contact, if they can whatever. It's going to allow the kid to be way more calm so that you can do your job. We're going to do our assessments normally. We're going to do our vital signs as per normal. And based on what we find, we're going to arrange for transport, right? Now, as we move into problems where the person is, the little person is not responding correctly, they're in severe respiratory failure. We had distress earlier, but now we've moved into failure where they're really not breathing well, they're wearing out, their breathing rate drops down below normals, the minimum expectations, if you will, and we start to see them with that listless look. We're going to have to take some drastic measures to help them out. They're probably going in unresponsive, and we will see a decrease in their heart rate. If the heart rate goes absent, then you already know we've got to move into CPR, right? But as it decreases, as the patient has less oxygen in them, as they're breathing less, the body is attempting to save itself by slowing everything down for a moment. The problem is, if it goes too slow, we move into cardiac arrest. So we really have to be cognizant of the respiratory rate. So if I can bag for a patient at the normal appropriate rates, I'd probably breathe for an infant and a child one every 3 seconds because they breathe faster. Then their heart rate should commensurately come up. If I have to do mouth to mask ventilations, make that happen, but I'd rather use the BVM with attached high flow oxygen. Um, that is the better play, right? Our standards nowadays, there's no reason not to have an oxygen bottle with you, a small little one with a BVM. Get going here. Now, remember, according to American Heart Association, in children and infants, if their heart rate is absent or less than 60 a minute, we're supposed to begin CPR, right? And if the heart rate is between 60 and 100, well, then we're going to assist with BVM. We're going to bag valve mask or override breathe for them. And this is an instance where we need to have all hands on deck. Make sure those transport units are rolling in hot so they know what's going on and they're prepared for what they're about to walk into. Again, the number one cause of cardiac arrest in children and infants is respiratory failure. So we need to take care of that respiratory failure first. Even if they go into respiratory arrest, we can prevent cardiac arrest if we're aggressive enough. Circulation failure, we already talked about it, 60 beats or less. And we need to get right on into CPR. If there's two rescuers, it's 50 to 2. Aggressive airway saves the day, and barring that, we need to get on to CPR. Now, coming back out of that for a minute, if we're talking about an altered mental status, just like in the adults, there are many reasons for the altered mental status. A low blood sugar, they could be a type 1 diabetic and they're born that way. That would suck, but that does happen. They could be poisoned, that's why they're altered. They could be post-seizure, which is going to tell me that they're probably sick. They have an infection or they're sick and they have a high fever. Maybe they've got bonked on the head. Again, the number one cause of death in children and infants is trauma. And then you have the decreased oxygen levels, which again is going to lead to that altered mental status, just like the adults. We have to complete that complete assessment. We can't jump around. It's ABCs, full body assessment, sample history, looking over the body. We've got to do all of those things. We can't jump around. So pay particular attention to a patient's initial vital signs, that baseline set of vital signs, because you'll see trending analysis as it goes along. We want to make sure that we don't miss any key indicators for that, right? We need to always be ready to support ABCs, right? Unconscious patients in recovery position, we want them on their side so they can breathe, even in the event of mucus in the airway or puke. Don't forget to keep the patient's parents calm too. All right, because infants breathe primarily through their noses, they're nose breathers, they're obligatory nose breathers, even a minor cold can cause problems. Compounded, in fact, if they have asthma, if they have another breathing thing, right? So make sure that we're treating them as per normal. And the parents may not know they have asthma. If there's no history of asthma in the family, and the kid's wheezing and they're like, I don't know what's going on here, they might need to be, trained in, hey, your kid's having a problem, we need to take care of this. Uh, we have to make sure that we're calming the parents, because the more stress that the parent portrays is the more stress the child will portray. It's just the way it goes. Obviously, just as a regular asthma patient, if there is such a thing as a regular, we want them to be sitting up. We want to give them some oxygen. If they have medicine, help them get it in there. We want to get a immediate transport going on, if that be, especially if it's uncorrected. There you go, uncorrected. Make sure the parent is helping out if possible. Now let's move into a different respiratory problem, one we haven't talked about yet. It's called croup, and this illness is typically hitting of a child between the age of 6 months and 6 years. So not typically for anybody older than that, but excuse me, it results in a hoarseness, and it's a barking cough, a seal-like barking cough, as they're trying to cough and clear their airway. It's a dry, harsh cough. Okay, typically in colder climates is where you'll see this kind of kick in, and the kid is going to look sick, not going to feel good. Probably has a little bit of fever, uh, and not going to want to lie down because it's hard to breathe. Uh, and there's a difference between that seal-like bark and epiglottitis. We'll talk about epiglottitis here in just a second. But basically, what you want to do is we want to have humidified oxygen. All right, moist, warm air that relaxes things down and allows for deeper breathing. The croup typically affects the vocal cord area, right? And so if those get inflamed, then then it's gonna be harder to breathe. On top of that, if it's harder to breathe and we cause the kid stress and they start crying, we could cause them to kind of choke out a little bit, which is not what we want to do. Croup is different from epiglottis like this. Epiglottis, croup affects the vocal cords, where epiglottitis, I'm sorry, affects the epiglottis, which is that flap that covers the airway when you swallow. So if that is bigger and floppier already because of the anatomical differences, now we make it inflamed because of the epiglottitis. The kid's not going to want to swallow. All right, they're going to be drooling. They're going to be sitting forward, typically between the age of 3 and 6 years old. And these are typically the ones that haven't been vaccinated against anything. These are the anti-vaxxers. Uh, it's just, so they'll be sitting forward and they'll be drooling and they're going to look sick. We definitely don't want to irritate them, because if they get to crying and that epiglottis slaps closed and is bigger, floppier against a more funnel shaped airway, it could stay lodged in there. And now we have to treat for airway blockage and other things that would be unpleasant. Usually sitting upright, doesn't want to swallow, is not coughing, drooling a lot, anxious and frightened, and chin is thrust forward because they're trying to keep that instinctually, they're trying to keep that tongue away from the back of the throat so that they can breathe a little bit better. Comfortable and calm as humanly possible. Don't move them around a lot. Give them oxygen. Make sure that we're getting transport happening. Okay. Now, drowning is where they're submerged, right? Underneath water. And it could be in a pool, but it could also be in a pond. It could also be in a bathtub, right? It's the second leading cause, most common cause of accidental death in children under 5, right? So we have to be aware of that as we start talking about the drowning portion of it. We don't do anything that's going to cause more danger to ourselves. Reach, throw, row, go with support is what I've been trained in. But if you're not comfortable getting into the water, if you can't swim, then don't be a part of the problem, right? If it's fast water rescue and you haven't been trained that way, you're creating more problems than helping. We've got to be able to be uh, good rescuers and self-preservers as well. Signs and symptoms of drowning: clearly no breathing, no pulse. Right? They've been underwater. We're going to go to the ABCs. We're going to suction if necessary. We're going to start our CPR if necessary. Once we get them cleared out, if they begin talking or coughing and throwing up water as you see in the movies, make sure that we drain all the water out of the mouth, suction if necessary. Typically, with water injuries, we're going to be thinking about neck injuries as well. Did they dive in and bonk their head on the bottom of the pool? I can't tell you how many times I hit the bottom of the pool. And I've hit hard too. I'm like, ow, that hurt. Had I hit harder, I could have been knocked unconscious. And well, maybe that's wrong. It's wrong. But stabilize the neck and make sure that we're warming them up. Because even on a summer day, that water is going to be below their body temperature. I don't know of any water temperature that people like to swim around in. It's 98.6 degrees, unless you're my grandmother, and that had to be 92 degrees in the pool before she'd go in it. Make sure that you're arranged for medical transport as soon as humanly possible. With heat-related illness and injury, we need to get that kid cooled off. So we strip off their clothes, we get them cooling off. Uh, I don't know about wrapping the child in wet sheets, but definitely want to get the kid moistened up with whatever the fluid is, so that they can start evaporating a little bit uh, and drawing that heat away from them. This is a critical injury, excuse me, illness, because if left uncorrected, the kid could go into seizure activity, and then we are down the rabbit hole of CPR and everything else. With that being said, fevers are pretty common in kids because their immune systems are ramping up to take care of themselves for their lives, right? And so they're going to be sick like all the time initially, as their body learns how to take care of itself. However, when we get above 104 degrees temperature, now we start to have gain damage. Now we start to have seizures. Now we have started other difficulties. So we want to cool them down. We want to keep them a low grade fever for a while. It's not too bad. But once you get up to 103, 104, we start red alerting here. 105, 106 typically is when we start seeing the seizure activity and the brain damage going on. So we want to be careful with that. Make sure you uncover the child and let the heat escape. Well, they're going to get cold. That's the point. They need to cool off, right? Um, Being sick and having a fever are two different things. They might go together sometimes, but we need to make sure that they don't get too high in the fever. It will hurt their brain. Fan them off. Cool them off. Make sure that they're breathing. If they seize, make sure that they start breathing again after the seizure's over. Speaking of seizures, most of the time it's from high fever. But there are some inherent diseases like epilepsy where the brain has that problem already. You don't really see it manifest right is in the younglings right off the bat, but there are those cases, right? Now during a seizure, just like in the adult, you're going to see loss of consciousness, clenching and jerking motions, that tonic-clonic movements, eyes rolled back, all that kind of thing. We got to be paying attention. How long does the seizure last, and do they come conscious again after the seizure? Right now, if during the seizure their skin becomes pale or blue, we need to support their airway. And the deep seizures, they might pee or poop themselves, just like in the adult. Those when they lose continence, when they're incontinent, that's telling us that it's a pretty bad seizure. And if they're seizing, why don't you go ahead and place them on the floor, or if they're on a couch, or just make sure they're not going to hurt themselves, and make sure that the airway is open. High flow oxygen, arrange for transport, monitor ABCs, and if the seizure is a result of a high fever, cool them down. Okay. Other things that we may see: vomiting and diarrhea, right? They ate something they don't agree with. They're sick already. Um, maybe I don't know. Maybe they've got the icky poo poos. With the diarrhea and vomiting, we've got to be very careful because again, the children and the infants don't have a lot of reserves, and because they don't have a lot of reserves, losing that much fluid could cause a dehydration. They lose that dehydration. Now I don't have enough fluid to keep the brain working right. I don't have enough fluid to keep the brain working right. Now I've got altered mental status. See how this all works together? So dehydrated children are lethargic, dry skin, and it's hard to replace fluids in somebody that is semi-conscious because they can't drink properly. So those kids will need to go to the hospital and get an IV. Okay, get them back on track. Complaining of abdominal pains, typically speaking, appendicitis is a young person's problem. 10 to 25 years old is typically when we see that. Um, Nauseated, don't really want to eat, wants to kind of dry vomit sometimes, dry heaves. Um, if it's on the right quadrant, upper right quadrant of the human, typically speaking, of the abdomen, upper right quadrant of the abdomen, it's probably an appendix. Get that looked at. If it ruptures, now we're going to go septic, and we don't want to have that going on for them. So we want to make sure that they're getting transported to the hospital and that looked at. Poisoning is a big thing. It's anything that's into the body that's not supposed to be there. Now remember the four routes of getting poisons into a body are ingestion, injection, inhalation, or absorption. For children, ingestion is going to be one of those main things because they're always putting things in their mouth. So you're going to look, if the kid's complaining of abdominal pain and not feeling good, and they're not acting right, and you see something around their mouth, chemical burns or different colors, what are they eating today? Was that a piece of candy that caused your tongue to go blue, or were they drinking Drano? You know, nausea, vomiting, diarrhea. We've already talked about all of those things. And then a decrease in respirations, unconsciousness, and seizures. Now, on top of the poisoning, we're dealing with the signs and symptoms, which are already not good. If we know what the poison is, let's take it with us, call poison control, gather it so they can be taken to the hospital and cared for there. We already talked about that. Make sure uh, water and activated charcoal, if indicated, uh, again, it's got to be ingested. They have to eat it or drink it, and arrange for, again, for prompt transport. The other point would be I'm absorbing stuff and I get into something. I went into this, the kid was playing around in the shed and some of the chemicals fell on him. Again, this might be a local problem or it might be a systemic problem. But in either case, what's causing the issue, stop that issue from going, right? So we got to get them out of those clothes, right? We need to get the patient out of those clothes, out of the contact, and start washing them off. But make sure that you yourself don't become exposed to this poison because, rushing in where angels fear to tread is not good because now we have a second patient. Just like any other poisoning, if it's dry chem, brush it off first, then wash it off. And again, if you can identify the poison, go ahead and make sure that you get that note down there so they can tailor their treatment plans at the hospital. Again, with the monitoring of any vital sign changes, right? Um, if they vomited and you can save a sample, super. But it's been my experience that most of the time they don't care. They'll get their own samples later on. Make sure you get transport going on. Okay, this one here is a sad, sad moment. I've been on a couple of these in my career. It's also called crib death, sudden infant death syndrome, SIDS. It's where uh, a child, typically between 3 weeks and 7 months, just dies. Right? Um, there's really no explanation. We're doing the best we can with limited information. You know, they just pass away. There's things that we can do to eliminate possible causes, but again, there's not enough information to know what it is. There's no scientific explanation. when this happens, the parents are going to be hysterical. They're going to be out of, they're not going to act right. So remember the stages of grief from our behavioral emergencies, from our wellness of the EMR in the beginning. Make sure that we're paying attention to them and being compassionate to them. However, if the infant is still warm, begin CPR and continue CPR. Um, if the kid has been gone for a while and there's large bruise-like blotches, remember lividity is where the blood pools to the lowest part. And so we don't want to compound a parent's grief of their child dying with accusations of child abuse. It is something that we have to be thinking about. But lividity is where all the fluids pool to the lower level. Typically, SIDS happens when the kid goes and takes a nap. You know, they put the infant down in the crib for a nap, and parents go and lay down. A couple hours later, they get up and the infant's dead. So we got to be very kind and compassionate and very mindful of what we say and how we act and what our facial tissues are doing as well. Okay, so now that we've covered medical reasons, let's talk about the number one cause of death in children. Right? It's the number one killer of children and infants because it's so it's damaging to their little bodies, right? And the other part of it is even after the trauma is over, typically the little ones can't tell you what hurts or why. They just know they don't feel good, and especially with adults, they don't know that fear that they have is going to trump their pain, right? Not all of our materials are set for little children's sizes, so we have to be very aware of that. And children don't typically show signs and symptoms of shock right away. But when they decompensate, when they start going down the tubes, they go quickly. The first indication of shock in a pediatric patient is a delayed cap refill. So if you got to squeeze their finger or their toe and it doesn't fill back up fast enough, that's an indication that there's something going wrong on the inside. They're in a state of shock. And so we need to be moving on that hyper quick because again, when they decide to dive off that cliff, it's a straight down drop. What was the trauma? What were they doing to cause the injury? And what do I see anatomically on the child? Probably some of the worst um, traumas are children that are in vehicles that are unrestrained. They bounce around like popcorn in there and they're just destroyed. And even if they are restrained in there, if they're not restrained properly, that could cause them to be sliced in half by their own safety devices. I've seen it happen. And so I know that it happens. We have to really look at the MOI. What's the mechanism of injury here? Now, unrestrained patients, you've got all kinds. Look at this. Unrestrained head, neck, and back pains. They're mashed potatoes. Uh, but with the restrained patients in the motor vehicle accidents, they got some belly pains too. Again, because they don't like that lap belt on them, right? And so it's not on there right, and they bruise up and they have all kinds of issues. Um, Kids with helmets is a good thing. However, we all know kids, and I survived without a bike helmet, sort of. Maybe I don't know. But when they're hit, typically speaking, these accidents, it's head, spinal, belly pains, uh, extremities on the bicycle accidents. Okay. Now this graphic here shows you what happens if a kid's hit by a car, right? So an adult, if they see danger coming, they will turn away from it. They'll typically take the hit on their sides. Whereas when a kid sees danger, they turn towards it, just like a deer. It's that deer in the headlight look. Oh crap! It's coming right at me. What do I do? Well, now you're facing the injury. They take the bumper right to the chest, smash their face on the hood there, and then smash their head on the ground. Right. So it's head, spine, and extremity injuries. Most of the time, abdominal injuries as well. It's just yeah, broken pieces. Also, with trauma, if there's burns to a little person, those are more severe than adult, again, because the proportions are not the same. What do we do? Same thing as we do for everybody else. ABCs. ABCs. Stop the bleeding. Treat for shock. You need to look over the entire body again because the kid may not tell you what's going on, or maybe they don't know how to tell you. Any injuries you find, stabilize. Any open wounds, treat them. Right. The signs and symptoms of shock are not going to be as quick as adults. So again, yes, they might be cool and clammy, but they're going to hold that for a while before they get to the decomposition mode where everything just drops out. Um, and again, that delayed cap refill should be something we want to be looking for in any of the patients, but most specifically in children with trauma injuries. Again, seizures will be as a result of trauma to the head in this instance, or a decrease in oxygen. Um, Broken teeth, broken jaw might obstruct, might swell. We're going to have to be aggressive with that airway because, again, without an airway, every patient dies. Oh, this little one does not like being held into place, but you're going to have to. Now, if the car seat is, in fact, still in one piece, it's done its job, yay, car seat. You can use the car seat as your immobilization device. And you just pad those voids and tape the kid into place. Okay? If you can, leave them in the car seat. But however, I just want you to know that if there's a car accident, typically the first thing the parents do is reach around and unbuckle them so they can cuddle them and hold them, right? So if they're up and moving, that'll be a good assessment beginning, right? You can do the PAT assessment. And then we got to talk about abuse. If there's one trigger in my existence as a rescuer, it's abuse. I don't tolerate abuse to anyone at all. And it engenders feelings of anger. And so we have to know that about ourselves, right? So when you're faced with it, you can control those feelings and get the job done. But in child abuse, if a child is fearful of rescuers, is unwilling to talk to rescuers, withdrawn, that's it's a fine line because is that them being a young person or is that them hiding from adult creatures? We don't know. Whatever injuries the child has, we treat them. But if the injury pattern doesn't match the story, well, then we got to start asking questions. Typically speaking, it's hard to break your arm by falling out of bed, even a bunk bed. Yeah, you might get hurt, you might have a bruise, but and multiple bruises and multiple stages of healing. Now, kids are accident prone anyway because their bodies are growing and their proportions are changing. However, it shouldn't be multiple bruises in multiple places in multiple states of healing, right? Right? And if you've been out there multiple times because the child's just clumsy, now it's time to start asking some different questions. We already talked about that. If we see human bites, ooh, that's bad. Uh, Bizarre accidents, like they climbed up on the roof and jumped off. What? Why? Right? That doesn't make sense. Here's some indications of boy, that really. I've seen these a zillion times, but I still get mad. This is smacking of the buttocks on A, human bite on B, right? Where just they're mad at the child, so they bite them. And then the one on the bottom is a dipping burn, where the infant was not being quiet, the child was not being quiet, and so they dip the child in burning boiling water. Um, and you see cigarette burns, all kinds of other things, branding and that. When you see that, treat the child with compassion and love as best as humanly possible. Avoid accusing anybody, but definitely get law enforcement out there. Law enforcement has got to be there. But I wouldn't get on the radio in front of the parents and say, I need law enforcement out here, because they could kick you out of their building and finish killing the child. So we have to be very, very good. aware of that as far as abuse. Now, there's also the other side of it where there's neglect, where a child is hungry, child is emaciated, um, they have just a horrible living environment, and the parent doesn't seem to care or recognize that it is a bad environment. That's neglect. Not, and there's people that would say, well, that's not as bad as abuse. Okay, it's an altered atmosphere for a child, and it's not good in either case. Still needs to report. We are mandatory reporters, which means if we see these things, we need to report these things. Sexual assault against children. Um, they might be beaten in their private areas. There might be ripping and tearing, bleeding. We need to take care of the child as best as humanly possible, as compassionate as humanly possible. And remember, they're not going to trust adults. So you're going to have to work hard to earn their trust. And we need to take care of them. So we don't need to have 25 people after them, right? Um, make sure that they're receiving appropriate care and be a patient advocate. Okay? What do we do after these calls for kids across the board? We need to have a debrief. We need a critical incident stress debrief because just giving this lecture has caused me to remember so many of the children that I've taken care of over the years that had horrific outcomes. And if you don't talk about them, if you don't get those feelings out, that frustration, that anger is going to fester like a cancer inside of yourself, and it'll burn you out to the point where you don't want to help anymore. Right? CISDs, incident stress debriefs, are about feelings. They're not about fault. It's how do I cope with this in a healthy manner? You know, I'm going to go to the gym and take a run. I'm going to go down to the gym and hit the heavy bag for a while. You have got to have healthy coping mechanisms, or you will not survive in this career field. Even if this isn't a career field, if this is just I'm helping out when I'm at home, you won't survive in this if you don't have healthy mechanisms. Okay? All right, that's chapter 17. Let's talk about some summary right now. There's a lot to remember, a lot of key points that we often overlook, right? The anatomy, again, is different between adults and children. Allow that to allow yourself to remember that so that you don't get overly aggressive in the wrong places and times. Involve the parent as much as possible. Uh, make sure that everybody is as calm as humanly possible because the kid will pick up the anxiousness of the parent and the parent is going to pick up the anxiousness of you. So you have to make sure that you are together in calming the patient down. Remember the airway of the infant child is smaller and more funnel shaped, easier to occlude. Unresponsive kids, we need to go right after them. What's the illness? What's the injury? Let's figure this out. We're going to do that by using the PAT assessment, right? Appearance, work of breathing, circulation of the skin. Airway saves the day all of the time. And if there is an airway obstruction and we can clear it, we do. But if they're breathing, we leave it alone and let the other people at the hospital take care of it. We also know that we need to do with the complete problems. We can do the Heimlich maneuver for the conscious child, back blows, chest thrusts for the unconscious infant, and in either case, if they go unresponsive, we begin CPR. Respiratory distress is the #1 cause of cardiac arrest in children and infants. The most the most severe of the respiratory problems, asthma, croup, and epiglottitis, right? Asthma, much the same as an adult. Croup, that seal-like barking, and epiglottitis, that drooling and ill look. Okay. Other emergencies that could be trauma or medical, we have drowning, and that could be just be in a bathtub. Heat-related illnesses, high fevers are going to cause seizures, typically speaking. Vomiting and diarrhea, they're going to go dehydrated, and then we have to figure out why they have abdominal pain going Two most common types of routes of poisoning is ingestion, I eat it, or absorption, it enters through they touch it, it goes in. In either case, let's try to identify what it is, make sure that we're safe, supportive care, get the kid to the hospital. SIDS is a crib death, unexpected, and it could be out of an apparently healthy infant. Supportive care to the parents in this instance. Multiple trauma in a child is probably going to be lethal, so we got to be making sure that we're looking at all of the systems because they're smaller. And the, the the target's smaller, which means everything's more compact. And then finally, don't forget that in the event of child abuse or sexual assault, you're a mandatory reporter, and especially in the realm of children, we have to make sure that they are being cared for. All right, this is chapter 17.